Just an old sweet song keeps Georgia on my mind. Georgia on my mind.
Objectives in providing anesthesia and tumescence during hair restoration surgery include protecting the neurovascular structures, providing adequate analgesia for the patient, and provide adequate hemostasis while protecting the patient's neuroprotective reflexes. Performing any office-based surgery requires yourself and the staff to be prepared for life-threatening events. The most comforting aspect of hair restoration surgery is the low risk of complications that are encountered. Although no government registry exists, most hair transplant surgeons report less than a 1% rate of complication and an even lower rate of life-threatening emergencies. Potential emergencies to be encountered include myocardial infarction, dysrhythmias, seizures, hypovolemia, allergic reaction, drug interaction, hypo or hyperglycemia, hyperventilation, and a vasovagal event. In the hair surgical industry, what constitutes an appropriate level of emergency response is not clearly defined in the medical literature. Some argue ACLS skills are not required, and this may be difficult for office-based physicians who are unable to use their ACLS competencies and skill sets. To increase patient survivability after cardiac arrest, prospective studies now show that 2 early interventions, CPR and early defibrillation, are essential. To understand the use of local anesthesia in hair restoration surgery, it's important to understand basic anatomy. The scalp consists of 5 layers. The main neurovascular bundles lie below the dermis and above the galea epineuritica. The subgaleal layer is relatively avascular. Injections in this layer provide no benefit and potentially increase postoperative forehead edema. The blood supply of the scalp is from 5 pairs of arteries. 3 are off the external carotid artery and 2 are off the internal carotid. The supratrochlear and supraorbital artery supplies the forehead and mid-scalp. It eventually anastomoses with a network of arteries from the superficial temporal and occipital artery that are off the external carotid. The superficial temporal artery supplies the frontal and parietal portions of the scalp, while the occipital artery runs posteriorly to supply the posterior scalp. The posterior auricular artery, which is a branch of the external carotid, ascends behind the ear to supply the articular region of the scalp. For anesthesia of the donor harvesting site, this illustration demonstrates the location of the greater auricular nerve, greater occipital nerve, third occipital nerve, and lesser occipital nerve. Innervation of the recipient site is from the supratrochlear and supraorbital nerves that exit from the supraorbital foramen, and they supply innervation to approximately 1/2 to 2/3 of the recipient scalp tissues. Here I am preparing a previous strip patient for an FUE surgery. Hair restoration surgery is a clean contaminated procedure. One may use any antibacterial solution. I like using benzoylalkyl chloride. As seen here, the purple ink defines the safe donor area, and I'm performing a ring block using my tumescent solution. I use the vibration anesthesia device developed by Blaine Labs. This device is based upon the gate theory of pain to reduce stimulation to the small and large nerve fibers. From my personal and professional experience, this device decreases the pain sensation of local anesthesia. In providing anesthesia for this FUE case, I will inject my tumescent solution in the outlined boxes of the safe donor area, and then I'll wait approximately 10 minutes for adequate hemostasis and analgesia. This illustration demonstrates the tissue expansion effect of the subdermal plane with tumescent solution. This in turn decreases the exposure to the deeper neurovascular plexus to injury by either the FUT or FUE surgical technique. The recipient site anesthesia can be performed similar to the donor site with tumescent solution as shown here. Some surgeons prefer to use buffered lidocaine alone and then subsequently use the tumescent solution in the recipient site. Some surgeons prefer a nerve block of the supraorbital and supratrochlear nerve as opposed to a ring block. It needs to be emphasized that not all patients are eligible for elective hair cosmetic procedures. A thorough surgical medical history as well as a physical examination is absolutely essential to evaluate whether your patient represents a low or high risk for an elective procedure. It is a standard of care in the hair restoration profession to limit surgery to Class 1 or Class 2 patients with appropriate cardiac clearance. Our current understanding of tumescence, local anesthesia, and cutaneous surgery was first described in 1987 in the American Journal of Cosmetic Surgery by Dr. Jeffrey Klein. His work allows hair restoration surgeons to use tumescence with lidocaine at safe levels. His subsequent publication in 2000, Tumescence Technique, serves as the Bible for local tumescence and with great clarity details the technique of high-volume dilute medication field block using lidocaine at safe doses. It is beyond the scope of this presentation to acknowledge the amount of research performed. But to understand the safe use of lidocaine in hair restoration surgery, we need to understand the cytochrome P450. The cytochrome P450 superfamily is a large and diverse group of enzymes that catalyzes the oxidation of organic substances. The human cytochrome P450 is a membrane-associated protein located either in the inner membrane of the mitochondria or in the endoplasmic reticulum of cells. Cytochrome P450 belongs to a family of proteins containing a heme cofactor and therefore considered hemoproteins. The letter P in P450 represents the word pigment, as these enzymes are red because of their heme group. The number 450 represents the wavelength of the absorption maximum of this enzyme. While rare in hair restoration surgery, lidocaine toxicity can occur. Recognition of early signs is very important when performing surgery. Early signs of lidocaine toxicity include visual and auditory disturbances, lightheadedness, drowsiness, restlessness, and numbness of the tongue. Later symptoms include muscle fasciculations, unconsciousness, seizures, coma, and eventually cardiovascular depression and respiratory arrest. My preferred preoperative sedation medication combination is catapress 0.1 to 0.2 milligrams PO with the addition orally of 1 to 2 milligrams of Ativan. These medications do not interfere with lidocaine metabolism and has proven to give excellent results. The list of medications that interfere with lidocaine metabolism is extensive. Some of the more common products include Xanax, Halcion, diazepam, midazolam, Zoloft, Paxil, Lexapro, and Prozac. My tumescence solution consists of 0.9% sodium chloride, Marcaine, 1% lidocaine, along with a little bit of epinephrine, and of course a buffer of sodium bicarb. It is important for the surgeon to take away from this lecture that the fact of the outer bottle lidocaine maximum dose is 7 milligrams per kilogram. And that does not take into consideration drug interactions and the metabolism of lidocaine with the cytochrome P450 that may increase the blood levels of lidocaine. Modern-day hair restoration requires the adoption of tumescence anesthesia as a preferred method of anesthesia over higher doses of local lidocaine injections. Tumescence anesthesia is a standard of care when lidocaine concentrations are lower than the recognized 35 mg per kilogram maximum dose.
Georgia, Georgia, the whole day through, just an old sweet song keeps Georgia on my mind. Georgia on my mind. I said, Georgia, Georgia.